All right, I believe we're live now. So my name is Domingo Molina. I'm an orthopedic surgeon, and I'm here with David Anon, doctorate of physical therapy, working at Ohio Valley. And I'll be joining Springfield Orthopedics in August. This is a little bit of a preview before we do our full launch. So a little bit of my background. I'm trained at University of Kentucky in orthopedic surgery, and I'm finishing my fellowship at Texas Back Institute right now in orthopedic spine surgery. So our goal is to bring a comprehensive spine program to Springfield. And then, so David, you want to give us a little bit of introduction, a little bit of your background?
Yeah, I'm, my name's David Anon. I'm my doctorate in physical therapy. I got my undergraduate degree at Otterbein College in athletic training. Got my graduate degree at Ohio University. Wide range of experiences as far as that goes, just clinical wise, but kind of the interest in pain and this concept for me is, why do I hurt? I was exposed to several different kind of theories of treatment, like McKenzie method. Okay, that was supposed to be the be-all, end-all to the McKenzie therapist. Didn't work for everybody. DiMaggio didn't work for everybody. And so on and so forth. The silver bullet methods, and I think we've kind of wised up from. Okay.
Yeah, that used to be the kind of the go-to physical therapy script in residency was McKenzie back exercises and send them to therapy and hope that they do better. So a little bit about I also have a little bit of interest in chronic pain. I've given a couple of talks on chronic opioid use. Of course, that kind of initiated in Kentucky. Was kind of the ground zero on that. And I know that you kind of see a lot of that in Ohio as well. And I think spine, just spine or spine surgery in particular, is prone to a lot of patients with chronic pain, even orthopedics in general. So I really kind of wanted to start this series off, just talking about chronic pain, because I think a lot of patients out there, and hopefully people watching have either chronic pain themselves, and know patients or know their friends and family have chronic pain. So I guess in your experience, you want to touch a little bit about, just kind of what is chronic pain. I know from my standpoint, I see patients that come in and say, well, I've had, 3 or 4 back surgeries and I'm still in pain. From my experience, I have a more organic reason of why it happens. Either, they need more levels fused, or, maybe their surgery just wasn't what they needed. The list goes on and on. Kind of what your experience though, what is chronic pain to a physical therapist?
Kind of generally, you could always, fall back on that, I've had pain for 3 or more months. Generally when we see it, what it looks like to us, when the patients come in, kind of similar to yours. They've had several years of back pain, kind of, a lot of times the mechanism doesn't quite fit the how long they've had the pain, at what level of pain they're at now. Their histories don't match up. They're just progressively got worse and worse. Usually we're seeing them, sometimes it's 15, 20 years, 10, 15 years. And actually the patients with chronic pain are getting younger and younger for us. Chronic pain for me, it's that 3-month period, but, really it has minimally or doesn't respond to treatment. It's very wide, it's widespread. They had a local injury. Now it's progressively seems to spread across the back, down the legs, and progressively intensifying in those areas. So, you're kind of losing that kind of, that focal point of pain where, okay, the original injury, and now it's starting to become long-term and, covering kind of a widespread area.
All right. So in some of these cases where patients, let's say that I've offered all I can to offer them, and they say, well, you know what, doc, I'm just still not happy. I'm still in pain. You said you can't do anything for me surgically, and I think that they go into this route of what we call demoralization, where they're feeling, despair, hopelessness, they can't work. Are there still things that we can offer them? And I think that that's where we can bring, what we call the pain neuroscience education into the mix. And, I know a lot of people have a stigma of, well, don't send me to therapy again. I've already been to therapy, it doesn't work. What can we still offer these patients?
It's interesting you say that because we get that. It's my pain management doctor, is basically a step. They're just going through the motions. They have no intention on, putting forth an effort. I think partially that's because, they have hurt so long, so it's not going to get better. They've been told, okay, their tissues are bad. You're not going to get better. We need to keep going these routes and jump through these hoops. But, on our end of it, that doesn't mean their tissues are bad. On our end is, educating them on, okay, why are you still having pain? Yeah, you do have problems. There are some physical problems that need to be addressed, tissue problems as far as, it's not that it's healing. There are, imbalances and postural issues and stress strain issues, but also getting them to, okay, let's devote some time to these kind of individual experiences that kind of lead you to have this cycle of, progressively increasing pain.
So I think real quick on touching that. So, and I think that everybody thinks I'm crazy when I say this when I'm in clinic. I see patients come in with neck pain, and when I look at them and I do a really good physical exam, I say, you know what? I don't think it's your neck. I think that you maybe have a scapular stabilization problem, or, you have some areas that might need some trigger point work. And of course, as a surgeon, you don't have time to sit there and sort through all these patients and direct them to physical therapists that are going to, do scapular stabilization exercises for them. It's easier just to say your neck's always going to hurt, and send you on.
Mm-hmm.
How often do you see that where you actually get your hands on a patient and you say, hey, you know what, you don't really have something wrong with your neck. If you do these exercises, maybe stabilize your core better, and actually see good results from that?
We do. I think at that point, as far as we're concerned, we have to break through those misconceptions about where we're going with therapy, because like you said, it doesn't work to them because they've done it. They have a tissue problem. So, it's hard for them to see, okay, how do these things make me better? So I think, you talking about pain neuroscience education, it's kind of bringing those two things together, kind of graded exposure to address those issues, and also educating them on, okay, why do they hurt? And not necessarily coming from it from a, pain focused or disability perspective, but coming at it from a understanding the, kind of the neurophysiology of why they hurt too.
But I think people get into this cycle where, the chronic pain cycle, where they have an injury and then they experience pain, and then all of a sudden they're afraid of, well, if I don't move, then I won't hurt. And then it's just a constant cycle. Then they become chronically disabled, due to inactivity. And, my goal, and like we've talked, is to break that cycle. So what have you found most effective in trying to break that cycle in patients?
Honestly, I know a lot of the approach is, okay, let's do manual therapy. It hasn't been shown, in our experience, to be extremely effective. Really, where we get the best results are being able to. Now it's trickier. I mean, because they don't want to move, but kind of grading that movement and building up into, okay, we're increasing your time of moving. We're increasing Not overloading them, not overloading the tissues, but grading how much resistance or weight they're doing, focusing more on the movement. That's kind of where we see our best results. Modality, I mean, manual therapy comes in there, and it is effective, but they don't want to move, so they hurt. It's a fear to move. So if we're able to get them out of that, that's where we see kind of our best results. Because the problem is they're not moving.
So where do you see right now in the education that we do provide to patients, on the therapy side? When I send a patient to you, I've given them the risks and benefits, and I've told them about the surgery, that they're going to be in this horrible amount of pain.
Mm-hmm.
Is that the way to go, or should maybe we tailor our surgical education to, hey, this is how we're going to break that pain cycle, rather than me showing them a model, the spine, or where I'm going to drill, and and just kind of scares them?
Yeah, I think there's a lot of fear associated with surgery anyway. I think the kind of the better approach is to, as much as much as you can make it more palatable to them, kind of reduce the fear, talk to them more about, okay, you're going to hurt, pain is normal, those tissues will heal, it's good to move. The expectation is you're active afterwards. You do have some restrictions. Explaining the surgery, I don't necessarily, I think, it's definitely good to educate them on, okay, this is the type of surgery you're going to have, but, in our experience, it's not necessarily helpful to give them the graphic representation of, okay, this is what's going to happen to you. It's more helpful to, okay, this is the surgery, this is what I'm going to do, you're going to hurt. And kind of giving them the, kind of the softened version of, okay, on my end of it is, it's going to look much different than, what I want you to know, but, this is what's happening to you.
I think in some instances, I think that, the patients that have been shown, like I've given an example, piece of the disc we've taken out after a discectomy, that's given them more of a visual cue to break that cycle of pain, rather than just say, well, I did get a little bit of a disc material out, and they said, well, I'm still having pain. Maybe you didn't get it all the way out, and then they're left with this, this doubt in their mind, and which again further recreates the cycle that they're already on. Do you see this as far as therapy, in that you tell patients, hey, why don't you just stick to this program for a little bit, and then they see the outcomes and they say, hey, you know what, that actually wasn't too bad?
Yeah, that goes along with building trust with the patient. That's a little hard to sell right away. So I think that's part of the initial portion of therapy is, okay, educating them on, giving them that information on that's, more about, okay, this is, again, this is why you hurt. And, relating it to, the neural component, relating it to, the kind of the neurophysiology of it.
Do you think that prehabilitation is, because that's something that I wanted to bring to Springfield and Ohio Valley, and we talked about, therapy and getting patients prepped for surgery, increasing core strength, doing some of the McKenzie exercises and things like that, but doing them in such a way that you're telling patients the stronger you are going into surgery, the better your outcome is going to be.
Yeah, absolutely. I think an understanding of and having a better body awareness is huge, because those are hard things to initially train, but if they're familiar with it, they're understanding, we find those things tremendously helpful. One thing, in most low back patients, their breathing pattern is needs retrained. They have no pelvic floor. You go back to that old idea of the pop can. If that pop can's sealed at both ends, it's hard to crush. But if it's open at the top, it's easy to crush. So same thing. In order to be successful, the surgery fixes one part of the issue, but the therapy and the prehab, they address those other parts of the issue that have come along the way with the problems that led to their back surgery.
Right. Now, do you all work with any other specialties? I know we talked a little bit about some of the cognitive behavioral aspects of it. And again, I think there's a stigma when you tell patients, hey, you know what, there might be a psychological component. But a lot of these patients, workman's comp in particular, if they've had an injury that maybe was, particularly devastating to them, they might benefit from some of those. Do you all work with people like that?
We do. It's some of that, and you're right, there is a stigma with it. Sometimes all we can do is suggest it. When we're talking about workers' comp, there's a big component to, chronic pain and hesitation to go back to work, just because of, depression, issues with, maybe they have a very physical job. Maybe they don't see the benefits of going back, or they don't have good job satisfaction. I think those things, they do play a role, and we do have contacts to address that. We've used the social workers at the hospital on more than one occasion to address issues. Also,
and I think that's the unique thing about Ohio Valley is that it's a hospital, but in a sense that it's small. And I know that you work closely with Springfield Orthopedics. And so how much one-on-one care do y'all provide? Because I know that you and I have talked about kind of creating that prehabilitation program, and even some of the patients getting same day kind of therapy shown to them so they can, kind of leave feeling that they've accomplished something.
How much one-on-one do we do?
Yeah.
Our physical therapy department is very hands-on, and very, our treatments are, to say, there's some independent exercise programs, but we do a lot of one-on-one manual work, a lot of functional corrections. So that as far as our department is, I consider a strong point. They get an opportunity to ask questions. They have plenty of time to get to know the therapist, work with the therapist, and just get the benefit from their knowledge.
Do you think there's any benefit in maybe, and this might be a progressive idea to some surgeons, but the therapist doing some of the surgical education instead of somebody in the office if they're doing prehabilitation anyway?
We actually do that with the total joint program. And I think for the patient, it's a very good thing. The therapist generally has a very thorough knowledge of the body, very thorough knowledge of the pre and post expectations of how they'll feel. I don't think it's a very progressive idea. I think it's kind of the right way in order to, more adequately provide that education and provide that kind of complete care to the patient. I think, I'm a big proponent of, physicians and physical therapists meeting, because, we're the other end of the spectrum as far as the surgeons go. You do the surgery and, we're the other end. We're helping provide an environment for those tissues to heal safely, while also kind of rounding out the rest of the care following, following the surgery.
Right. I think that's something that I'm excited to work with you all on at Springfield Orthopedics in Ohio Valley, is that we, I talked to you about this when I went up there in February, is that, these patients that get these, anterior and posterior fusions or just back fusions, microdiscectomies, I want them all up the same day, after surgery. 3 hours later, we'll get them up and walk. And I think it's part of setting expectations for patients to say, hey, yeah, you know what, you're going to hurt a little bit, but we have these protocols for, medications, muscle relaxers, therapy protocols, and like we've talked about, doing a prehabilitation and getting them used to that idea even before surgery, I think is what's going to break a lot of this chronic pain cycle.
Yeah. Well, I think you're right. I mean, the explanation too, and I think this is, really what really helps get into the mind of patients, that that early movement. Most of your patients do well if they're up the first day. There's solid research on that. That's total joints. That's post-op fusions. The more time from that surgery that you go out, you go into the next day, you get them up. The outcomes, aren't as good. On the other end of it, as far as pain, the better movement you have, and the more you're able to move, to a point where, it's 50% of your aerobic capacity, you're actually getting a pain relieving response that's equivalent to, I think what it said was 10 milligrams of morphine,
Right.
which hard to believe, but it's out there. There's criteria to it, but getting the patient to understand that is key.
All right. Well, do y'all have any other interesting things coming up at Ohio Valley? I know, other than what we've talked about. We have me coming in August, and like I said, I hope to put a lot of these programs in place. Getting the patients to see you all before surgery, and then we'll get them up, like you said. Anything new coming in the pipeline though for you all? Or?
I think kind of the more exciting things are kind of revamping the Spine Academy, and kind of taking a little different approach to that. Kind of incorporating the pain neuroscience education into it. We're also kind of launching some telehealth, a telehealth program, which ties really nicely into what we've just talked about, because we can reach more patients. We can do this pre-surgery education. We can use it to intermittently, instead of having the patient come in for a visit and just sitting there and talking to them. We can do it through telehealth. So those are exciting things. Being able to reach the patient as a therapist, to better educate them, because a lot of times what we see, the pressure is to jump right into treatment. This kind of gives us a breath to gives us a breath to just sit down, have the patient ask questions, and just talk, and build that trust as treatment goes on.
All right. All right. Well, I look forward to working with everybody there, and I appreciate your time. And hopefully, like I said, this will maybe kick off somewhat of a mini series we can do to kind of educate patients. I think that, kind of touching on what you had said, I think just being more available to the patient, whether it's through telehealth or some educational webinars, is going to really be key, and I think something that'll be new and fresh to Springfield. So
yeah, and I think and I think the value of that with us, you know, especially with our chronic pain patients, and I think where you were getting at in the beginning, we see them after they've been through every disaster that they could be through, or be at that time. They've had a surgery, they've been to multiple pain management doctors, been to multiple therapies. None of it worked. So, I mean, the difficulty for us, and that's why we feel the pressure to jump right into treatment, is they're walking a tightrope. If we don't produce results really quickly, they either fall off or we've lost their interest. So, this kind of, it gives us an opportunity to do what we need to do and be effective.
Yeah, unfortunately, everybody wants a quick fix, and I always tell people, you're going to hate me because I'm going to tell you need physical therapy, but trust me, it's going to work. So,
well, like you said, the other thing is, all that anybody's ever focused on is how bad they are. The doctor said this is the worst back he's ever seen. I can hear that. I hear that multiple times. Yeah, this is the worst back, bulge he's ever seen. Worst herniation he's ever seen. This is the worst degeneration he's ever seen. Well, kind of pulling away from those terms and going, okay, well, aside from that, this is what we're going to do, and this is what we're going to talk about. So, I think, kind of removing some of that hopelessness with their pain is, it gives us an opportunity to, and this is a nice, pain neuroscience education is a nice way to approach it, and it's very understandable, and that's the whole goal. You're not even talking about pain. You're not even talking about disability necessarily. You're talking about, okay, what's your experience, and where we need to go from here. Because you can take the complexity out of why they're feeling their pain once and for all. It can be understandable to them. Okay, this is what happens. You get into this vicious cycle. Your body stops inhibiting those pain signals, and now, okay, you're far enough along, those tissues are healed, but now your threshold for pain is very, very low. So now, minor, I've had patients, I lightly put my hand on them, and they jump.
Right.
They talk about how they can't sleep because of the weight of the blanket. So, if you can get that calmed down, find out their socioeconomic, their emotional components, and the other gamut of things that go into it, that those are kind of exciting things, because it's going to take time. It's not going to be quick, but we can have way greater impact and actually improve their life. So, it's exciting.
And I think that's what's going to be good with our partnership, is that I think it takes both the therapist and the surgeon to back each other up on that. And like you said, not initiate the fear in the patient by saying, wow, this is the worst back, and then expect you to work wonders. So,
yeah.
All right. Well, I appreciate your time, David. And
absolutely. Great talking to you.
Look forward to working with you.
Yeah, absolutely. Thank you.
All right. Thank you.